Folks, welcome here. We have a full class today, expecting around 150 people here today, so that's just fantastic. My name is Sherry Lissy Sigerson, and I work at Shared Health, Mental Health and Addictions, and I'm happy to welcome you to RAAM KE Days. Today, I am going to pass over to Daniel Descombe, who will be our host for today, and we'll be introducing Dr. Knight. So welcome here, everybody. Thank you.
Hello, everybody. My name is Daniel Descombe, and I'll be your host for today. Um, we are very pleased to be joined by Dr. Erin Knight to do this presentation for us. She's done one of our RAAM KE Day presentations already, and this one promises to be just as good as the first one. As we're going through the presentation today, on the right-hand side of your screen, you'll notice an area to ask questions. And there will be an opportunity to answer some of these questions at the end. And also there may be some time during the presentation where Erin will be inviting questions or inviting commentary, and you can use that question box to add those comments as well. So I'm going to turn things over to Erin and just to briefly introduce her. Dr. Erin Knight is a fellowship-trained addiction and family physician. She's the medical director of addiction services at Health Science Center, medical lead for the RAAM clinics, and the medical director of the Island Lake Addiction Program. She also serves as the program director for the Addictions Medicine Enhanced Skills Residency Program at the University of Manitoba, and is current president of the Canadian Society of Addictions Medicine. Erin, so good to see you again. Thank you so much for doing this.
Thanks, Daniel. Okay, so we'll jump right into it. I'm going to be talking about some of the updates that have occurred over the last little while with regards to Sublocade. I am going to use the name Sublocade because saying injectable buprenorphine over and over again is a little bit challenging. So just keep that in mind. I do want to start with a little land acknowledgement. So I'm calling to you today from my home in Winnipeg on Treaty 1 territory. Land acknowledgement, I think, is always important in our work and thinking about not only where people are from and where they're spending their time, but their relationship to the land and the relationship to colonization and our history in Canada impacts the social determinants of health that also substantially impact substance use disorder development as well as substance use recovery. And in particular, thinking about kind of the geography of Manitoba and the different territories of Manitoba is really relevant when we're talking about the use of Sublocade because it is a strategy for treatment of opioid use disorder that really has allowed us to expand treatment outside of the urban centers. So has been a really big kind of game changer in terms of access to treatment for people who live in smaller remote communities. I don't have any disclosures. I don't have any relationships with industry or with pharma. The only thing, like I say, that is a disclosure is I will use the trade name today, only because there's not an alternative, and it's just simpler to reference Sublocade. So the learning objectives I have for today are to discuss how to use Sublocade as a treatment option for opioid use disorder, including going over some of the subtleties and updates related to the evidence, including in pregnancy, to some of the initiation strategies we can use for this medication, and some of the titration and dose or frequency adjustments that we can use. And then we're going to work through some cases. So as Daniel said, we're going to use that questions tool because I'm going to ask you some questions. So you can use that to put your answers in when I ask you questions, as well as to put questions in either throughout the talk or at the end. So starting off with some of the Sublocade evidence, This is old now. You'll see this is from 2019. This really is what led to Sublocade being approved for use in treatment of opioid use disorder. I think it's still super relevant, and I think it's really, really important for prescribers and for healthcare providers working with this medication to be aware that what this is a non-inferiority trial compared to placebo. So we actually don't have a study that shows that Sublocade is as good as or better than sublingual buprenorphine or methadone or any of the other alternative OAT options. So what we know is it's better than nothing. We don't know that it's better than our oral or sublingual medications. And that's really important. And we'll talk about that in the next slide. The Sublocade is covered by both EIA and treaty. There were previously some requirements in terms of how the duration of time that people were on buprenorphine first. That's all been removed at this point, and so they're just covered by both of those medication coverage options. So what I mean about the lack of a non-inferiority study compared to other OAT options, and why I care about that, is they almost certainly have done this study, and because it hasn't been published, there's a significant concern that this is a non-publication bias. So there's a thing that happens in research that's very common, that if a study is negative, it often doesn't get published either by the drug company or because there's less interest in publishing those studies. If you can imagine being a drug company with a new fancy medication that people are going to spend a bunch of money on, if you could show that it was better than other options, you would. So the fact that we don't have a non-inferiority study compared to other OAT options makes you significantly wonder whether it is actually inferior to those other options. That said, it's still a really, really good option for lots of people for lots of reasons. And so the reason I point this out, though, is for people who are otherwise stable on sublingual buprenorphine and they don't really have a compelling reason to switch. They're not having difficulty getting to the pharmacy. They're not having difficulty staying on the sublingual formulation, and they're fine just building some more flexibility over time. Then maybe we should just leave them alone and not suggest a switch over to Sublocade, because some people will likely destabilize or do worse on the injection than they will on the oral medication. And it does mean that some people will do better on other OAT options. Now, that said, sometimes Sublocade is really the only option for people, and it's better than nothing, and we clearly know that. So offering Sublocade to somebody who doesn't have the option of being on oral medications because of their location or because of the access to pharmacy is a better option than no treatment for opioid use disorder. Sublocade in pregnancy has evolved over time, as everybody who's started using this medication when it first got approved will know. It was a formal contraindication. Pregnancy was a formal contraindication at the beginning. There was some theoretical concern about the atrogel, which is the carrier compound, potentially causing some birth defects. Although when you look at the studies, the animal studies that developed that, it was in much higher dose concentrations than in the actual Sublocade injections. There is expanding observational data at this point that Sublocade does appear to be safe in pregnancy. So the article that I've included was published about a year ago now, and looked at some case series as well as post-marketing pregnancy data that had been submitted on Sublocade, and identified that at this point it looked like there was no substantial difficulties or problems with Sublocade in pregnancy. We're starting to have more local experience with using Sublocade in pregnancy as well. There hasn't been a ton of people supported through pregnancy on Sublocade so far, but it's expanding all the time, probably in about the 10 to 15 people range at this point. And again, it seems to be very well tolerated in pregnancy, and folks are doing well. Similar to my comment of, if people are doing well on sublingual on a different form of OAT, then we probably should just leave them alone and not switch them to Sublocade. Similarly, in pregnancy, if people are already on another form of OAT and are stable, we probably shouldn't be looking at switching them to Sublocade. But if an individual is presenting for care for their first time in pregnancy and Sublocade's the best option, then it is one of the menu of options that we can use for sure at this point. The next section I'm going to talk about is OAT inductions, and I'm actually going to talk about Suboxone for a couple of slides, just because it's part of the whole induction strategy, is we need to get people on buprenorphine first. So some of the things that I think about and that I encourage folks to think about when you're doing some planning for OAT starts is think about right away some of the logistical things. Where does the person live? Do they have access to any or all OAT options within the community? And even if the community has a pharmacy or a few pharmacies, it doesn't necessarily mean that those pharmacies stock or dispense OAT. So if you don't know that, it's important to call those pharmacies and ask about it. And make sure that they actually understand that they need to have a pharmacy that's trained in providing OAT medication there. Is that pharmacy actually really accessible to the patient? So is it something that the patient is going to be able to access on a regular basis, including up to daily if they need to continue on daily witnessed options? And then if it's not, that's really the area where Sublocade becomes the most useful in terms of supporting people who can't access pharmacy regularly. Do they have medication coverage? This is incredibly expensive medication if people have to pay out of pocket. If they do have some private coverage, is there a deductible that they have to get to first, or is there a maximum that's covered that after that they're going to have to go to pharmacare or pay out of pocket for? If they're covered through pharmacare, can they actually afford to pay for their medication until they hit their deductible, or would they benefit from getting onto the monthly payment plan that's available through Manitoba Hydro? And then finally, is there somebody who can actually follow this person? How are we going to support their ongoing access to care? So like I said, I'm going to talk a little bit about buprenorphine. So just as a reminder, this is stuff that you guys already know, but buprenorphine is a partial mu agonist at the mu opioid receptor with very, very high affinity. That's why we have to be cautious with how we start it, because if somebody has those full opioid agonist bound to the mu receptors, if we give them that high affinity partial agonist, it kicks off the full agonist and people go into precipitated withdrawal. Buprenorphine is an interesting opioid in that it's also a kappa opioid antagonist, which gives it some of the benefits that we see sometimes in terms of affect lift and mood lift. As opposed to almost all other opioids that are agonists of the kappa receptor. That's what causes some of the long-term sort of depression-like symptoms that people can experience with long-term opioid use. Oftentimes, if people get onto buprenorphine, either sublingual or injectable, they can have that sort of lift of their affect related to the kappa antagonism. Buprenorphine, when we're giving it in the sublingual form, it has good mucosal absorption, but very, very poor oral availability. So when you're doing particularly starts for people who have never been on it before, making sure that they really understand how to take it properly, so that they're not losing the medication by swallowing either the tablets themselves or the swallowing sort of the saliva as it's dissolving. This is, I'd say, particularly important when you're doing Suboxone starts or Suboxone dosing in the hospital if people are receiving other daily medications, because oftentimes I've seen it where the Suboxone gets put in the same med cup as all of the other daily medications, and unless the patient knows it and picks it out and takes it appropriately, it's really easy for people to just swallow their Suboxone if the staff within the hospital aren't as familiar with it. Half-life is somewhere between 24 to 32 hours. It's dose related, so the higher the doses, the longer it lasts. One of the nice things about buprenorphine sublingually is it hits its maximum effect at about an hour, so that means we can dose it really quickly and get people out of withdrawal. But there's a lot of variability in plasma levels, and so we just have to titrate it clinically. There's no sort of morphine equivalent that we know that somebody's going to stabilize on 16 or 20 or 24 milligrams. I'm not going to spend much time on this. Just a reminder that the naloxone is only in there to prevent people from either snorting or injecting. It really doesn't do anything else, with the one exception being if people have a really ineffective liver, they might lose the first pass metabolism, and that might cause people to have a little bit of withdrawal post Suboxone. I am going to spend a little bit of time here because I think this is something that is actually sort of new and evolving, and we're starting to see the need to be a little bit more creative about buprenorphine starts, particularly as we continue to deal with fentanyl. So everybody, I'm sure, is familiar with the two first kind of ways of starting people on buprenorphine, the traditional starts and the microdosing. I will point out with traditional, particularly when we're dealing with folks who are using high potency opioids or have a high tolerance, they've either been on buprenorphine before or they're just using large amounts of high potency opioids, and we think they're going to need to stabilize on a higher dose. The beauty of buprenorphine is that we can push the dose really quickly. So it is entirely reasonable to get somebody up to 16 milligrams on day 1 and then go up to 24 on day 2 and then go up to 32 on day 3 if we need to. The microdosing is a good alternative if somebody's presenting and they're not already in withdrawal. Although if I'm seeing somebody who's using a predictable short-acting opiate and they're not in withdrawal today in clinic, most of the time I'm actually going to prefer to get them back the next day in some withdrawal or go to the pharmacy in withdrawal and do a traditional start rather than doing a microdosing start, because the traditional start makes people feel better. And so we think there's better retention and care if we can do a traditional start with folks than doing a microdosing start. Microdosing, though, is really, really helpful in the context of fentanyl. If people just can't stop using fentanyl for long enough to do a traditional start, fentanyl is much more unpredictable in terms of the risk of precipitated withdrawal. So typically we're not doing traditional starts unless it's been at least 24 hours from last fentanyl use, just because when we started doing that, when fentanyl became more prevalent in Manitoba, we started seeing quite a lot of precipitated withdrawal events. Now, rapid microdosing is something we use mostly in hospital, which really kind of is the same principle as microdosing. We just do those doses much more frequently. So instead of doing a BID dosing, we're doing like a Q3-hour dosing. And all that does is it shortens the duration of the microdosing so that we can get people on a therapeutic dose generally by day 3 instead of day 5 or 6. And then finally, I did want to talk a little bit about macrodosing. This is much more common if you go to other places, if you go to Vancouver, if you go to Toronto, in a large kind of swath of places across Canada. Macrodosing has become a major way of getting people on buprenorphine, particularly in the context of fentanyl. So it's an alternative if people are presenting with fentanyl use. They aren't really appropriate for a traditional start because you're worried about precipitated withdrawal. They don't want to do a microdosing start because they just haven't been able to get through it, or they don't think that they're able to follow up with a microdosing start. So macrodosing is kind of just a really, really aggressive traditional start. You do want somebody to be in some opiate withdrawal, so cows of 12 or 13, and not having used fentanyl for at least kind of the last number of hours. It's basically using a big first dose, so 8 to 16 milligrams of buprenorphine, with a conversation with the individual that they might actually get some precipitated withdrawal. They might feel worse for the first little bit, but we're just going to treat that aggressively with more Suboxone. So this idea of going up to 24 or possibly even 32 milligrams on the first day with individuals who are accepting of that risk of some short-term withdrawal, with the idea of getting onto a therapeutic dose of buprenorphine today. And really is most appropriate for that person that you know has high tolerance, so somebody who's using grams of fentanyl a day and has not been able to stabilize with other methods. Some differences in hospital to highlight if anybody's doing hospital work is generally we can be more aggressive in hospital. So it's not uncommon for us to go right up to 32 milligrams in hospital the first day if we need to. And then the other nice thing is if we are doing microdosing starts in hospital, we can give people other opioids to treat their opioid withdrawal. It is something that you could consider doing in the outpatient setting as well. And there's lots of protocols about this that are available from other places where you might do a daily dispensed RAAM during a microdosing to try and alleviate some withdrawal symptoms. Not a common thing that I do as an outpatient, but something that we could think about. Then we'll get into the nuts and bolts of the Sublocade updates now. So the big recent developments are the new injection sites. So I'm going to talk about the last two bullets first, because those are the ones that are approved in Canada. So the new injection sites, not only the abdomen that we've always had, but also thigh, buttock, and upper arm. I don't have any experience with these other injection sites so far, but it's good to have alternate options if people don't want the abdominal injections, or if you're doing sort of stacked doses and you're running out of space on the abdomen, to have other places where you can do injections. The studies that led to the approval of those sites do show that they are a bit more painful, so it's just something to be mindful of. The other new change is for people who had previously been stable on some of the lower end doses of buprenorphine sublingual. We don't have to do two 300 milligram injections anymore, so we can just do one 300 milligram injection and then go to 100 milligrams ongoing from there. So for your person who's stabilized on 8 or 10 or 12 milligrams of sublingual buprenorphine, you can switch over to that 100 milligram injection quicker, which can be useful, particularly if people have pain or have difficulty tolerating the 300 milligram injection. And those are both on label in the Canadian monograph at this point. Some of the other evolving things are still off-label in Canada. So the first two are approved in the US, but are not approved in Canada yet. The first being rapid induction. So the concept of somebody who you're not worried about not tolerating the buprenorphine, as long as they tolerate a first dose of 4 milligrams of buprenorphine naloxone without precipitated withdrawal, then you can go ahead with the Sublocade 300 milligram injection an hour later. If you do employ this in Canada, it is off-label, so it should be documented as off-label, and you should have conversations about it being off-label as part of your informed consent conversation. The second evolving thing that again is approved in the US but not in Canada at this point is a substantial shortening of the dose interval. So being able to give, if people are having ongoing withdrawal symptoms after getting a 300 milligrams of Sublocade, you can give the next 300 milligrams as soon as on day 8, so weekly injections, up until it starts to last longer, and then gradually spread those injections out. Really useful tool if people have really high opioid tolerance and they want to be on Sublocade, or they've had difficulty staying on a daily witnessed OAT option, like even people who you might actually think would do better on methadone, but they just can't kind of follow up with the titration and the dosing. And this is an opportunity to support those folks. And then the third bullet point is something that we've started to do for folks who have a lower opioid tolerance, actually. So this is more relevant often to folks who are living in some of the remote communities where access to drugs is more limited and costs a lot. So even though people have a severe opioid use disorder, their tolerance is lower. So if you're doing a start and you're getting somebody up to 4 milligrams of Suboxone and they're actually feeling good at that, and if you go into higher doses, they start feeling like nauseous or having side effects from it, then the potential to, again, off-label, start them on 100 milligrams of Sublocade rather than 300, with the opportunity of repeating that if we need to. I did want to highlight the 2024 CRISM opioid use disorder guidelines, just so that people are aware of them. Of note, they do not address Sublocade at all. This is all about oral and sublingual forms of OAT, but kind of a useful overview of the other evidence behind treatment of opioid use disorder. All right, so then the next 3 slides, we're going to talk about some common clinical problems and approaches, and then we're going to go into some cases for the last little bit. So the first kind of common clinical problem that I get lots of questions about is they're not somebody who's not falling into that kind of traditional dose range of 8 to 24 milligrams of sublingual buprenorphine naloxone. So if they're tolerating less than 8 milligrams, our options really are to slowly titrate them up to that 8 milligrams daily, or as I just mentioned, potentially give them a 100 milligram first dose with the opportunity to repeat that if it is wearing off before the first 4 weeks. Again, this is off-label. It should be talked about as off-label and documented as off-label, but can be a strategy for people who have a lower opioid tolerance. On the flip side, if people are requiring more than 24 milligrams, that does indicate that they have a higher opioid tolerance. They are likely to have more difficulty in stabilizing on that traditional either 100 or 300 milligrams monthly. So when we first started using Sublocade, there was lots of sort of using of top-up Suboxone in these folks. So when the injection started to wear off, using 2 to 4 to 6 milligrams of Suboxone daily to bridge them until their next injection. But for a lot of folks, this sort of nullifies the point of being on Sublocade. They wanted to be on Sublocade because they didn't want to have to go to the pharmacy regularly or take daily medications. So evolving more and more towards just shortening the duration between the doses. So obviously, if somebody is on 100 milligrams monthly and it's wearing off, let's switch them to the 300 milligrams monthly. But if they're on 300 milligrams and they're having it wearing off early, just shortening the duration beyond the on-label. So again, document it and discuss it as off-label, but we can shorten the duration to 2 or 3 weeks between injections for folks, and that can provide some stability. And for some people, it just needs to be done for a period of time, and then we can gradually expand the time frame after a period of stabilization as well. This is a very similar sort of situation to the last one, but just people coming in reporting that it's wearing off early. Again, if they're on the 100 milligram dose, we'll just increase the dose, and if they're on the 300 milligram, increase the frequency. And then finally, sort of, somebody is coming in really late, so they're outside of the window. As you know, the on-label dosing can be anywhere from 26 to 42 days from last injection. So in that sort of 6 to 8 to 10 weeks from last injection, what do we do if somebody is coming in late for their next injection? So some of the things that I think about and that I try and explore with folks, or have the nurses explore with folks if they're presenting somewhere without a physician present, is like, what happened? Why didn't you come? Sometimes it's actually that people were feeling really well and they actually are only presenting now because it just started to wear off recently, which is a very different thing than if somebody is, if it wore off after 2 weeks and people went back to using full agonists and have been using heavily over the last little while. Those are two really different clinical scenarios. So why did they miss their dose? How are they feeling? Are they using any other opioids? And then your point of care urine drug screen can be helpful too in guiding what you do from there. You do anticipate that people will still be positive for buprenorphine because the Sublocade does take quite a long time for it to wash out. But whether or not there are other opioids on board can guide you in terms of what you do. So if somebody is positive for buprenorphine but negative for opioids, and they're presenting late because they were feeling well. If they were previously on 300 milligrams, then this is a good opportunity to get them down to 100 because it's clearly lasting longer than it needs to, and then book them for a month. If prior to this they were on 100 milligrams and it's now been an expanded period of time, the only thing that I would have any concern about is has it washed out enough that they're now not going to feel well or not going to tolerate the next injection. So to test that, you can give them an 8 milligram test dose, make sure they don't look sedated, make sure they don't have side effects. And then as long as they're feeling well, at least an hour after, then give them the 100 milligram injection and continue on. For the person who has gone back to opioids, the sort of bigger concern is whether or not the buprenorphine has worn off enough that you are at risk of causing precipitated withdrawal if you give the next one. So again, you can use a test dose to do that. So for 8 milligram test dose of buprenorphine, make sure they don't go into precipitated withdrawal, make sure they feel well, and then go ahead with your next injection. And then sort of the decision around dose for that injection will just depend on why the person missed their dose in the first place, whether or not you continue on the same dose or increase it if they were on the 100 milligrams. So that's sort of the crux of information I wanted to throw at you, and I know it's a lot. So the last sort of 10 minutes I wanted to spend going through a couple of cases. This isn't the best platform for interactivity, so unfortunately you can't sort of unmute yourselves and have conversations with me, but I'm going to ask you to just use that Q&A section of the platform to respond and to put your thoughts in, and I'll be able to read them out loud. First case is, all of these cases are some conglomerate of people that I've seen that are de-identified, obviously, and a mishmash of sort of presenting symptoms. But case one, 54-year-old woman who's connected to primary care, and their PCP actually prescribes OAT, but they've had multiple unsuccessful attempts at buprenorphine starts, using high doses of down daily, really every few hours throughout the day, can't go very long without. Last use this morning, approximately 6 a.m., you're seeing them in the afternoon. They're already at a COWS of 12, about 6 hours after their last use. And they're saying they really, really want to get on Sublocade. What are some of the strategies you might try and use to try and support their goal of getting on Sublocade? In terms of how you might start buprenorphine or how you might employ Sublocade. I'm not sure if this will work, but I hope somebody will type something.
Hi, Aaron. It's Daniel. I'm keeping an eye on the question thread as well. There is a question in there, but it's not a response to your case study currently.
I don't see the question then, so I can't. Because I have the questions open and I don't see it.
Okay, I can read you the question.
Mm-hmm.
I'll put my camera back on so people can see me. So the question is from Johnny Mexico, and it says, can folks still use and get a bit high while on the rapid induction? Would this provide a bit more cover for a potential overdose?
So people can still use on any form of buprenorphine, though it does block a lot of the euphoric effects from other opioids, and so it really depends on what dose people are on. As soon as people get into sort of the 16 milligram range of sublingual buprenorphine, it does provide pretty good blockade effect of some of the euphoric effects. Not to say that it blocks it entirely, but it is one of the realities of buprenorphine, is it blocks some of that. Typically when people are doing microdosing, whether that's a rapid microdosing or a regular microdosing, they are continuing to use other opioids because it's not going to be enough of a dose for those first few days that they're going to have any benefit from it.
Okay, thank you. I am seeing now some responses coming into the questions area. So I think the first response to your case study says test dose if good rapid induction with short duration follow-up.
Yeah, so that's a great suggestion. I see a couple other recommendations. I see a recommendation for rapid microdosing, asking if she's ever heard about Sublocade. She has. She wants to be on Sublocade. She's just a little bit worried that it's not going to work for her, but she absolutely wants to be on Sublocade. So yeah, this is an individual. She has had multiple trials of microdosing. She absolutely tells you she does not want a microdosing kit today. It's not worked for her. She's not. She knows she's not going to come back if you give her a microdosing kit today. So she is actually somebody I did a macrodosing start on. So we did 8 milligrams of Suboxone. We repeated 8 milligrams again an hour later, and then we went up to 24 milligrams the first day. We got her in the next day, and we did a Sublocade injection. And then we did weekly Sublocade injections for about 5 weeks. So kind of talked to her right from the get-go of like, we know that that this might not feel perfect, but we can be as aggressive as we can be with this. Again, having the conversation that this is off-label, but it's something that they are that is approved in the U.S. That's something that there is some research evidence for, and she was open to that, and so we were able to get her onto Sublocade on day 2, and then maintained care.
Okay. You can see the other comments that are coming in.
I can see 3 comments so far. Oh no.
Okay.
There's did she get 2 300s for the first 2 and then 200 milligrams? She got 300 milligrams every week for I think 5 weeks, and then we started spreading them out.
Okay.
What is the difference between methadone and Suboxone? That is the sort of high level response to that is they're both first-line medications for treatment of opioid use disorder or opioid addiction. Suboxone is a tablet that goes under the tongue versus methadone that is a liquid medication that's swallowed. The big difference between the two really is that methadone is what's called a full agonist, so it binds to the opiate receptors and turns them on all the way, versus buprenorphine or Suboxone being a partial agonist. What that really translates to is that Suboxone is a safer medication when it comes to side effects and overdose potential. And so it is, because of that, is more flexible for people to be able to take doses home more quickly, and we can also titrate it so we can get people to a therapeutic dose much quicker than we can with methadone. That said, like, both medications are good treatments, and so it's just picking what the best medication is for each individual person. There's a question about, was the weekly dose based on withdrawal symptoms, and then the spread out as tolerated? Yes, exactly. So the only reason we were doing weekly injections was because she was presenting with ongoing withdrawal symptoms. So we did them every week. So basically with her, we anticipated that was going to be the case. And so at the first injection, ordered the next injection right away so we would have it in stock, and then booked her for a weekly follow-up with the option of not giving the injection if she was still feeling okay. So that's how we started kind of spreading them out, was just when the first time that she presented for her weekly follow-up and was feeling fine, we just skipped it. Great. I'm going to go down to the next case.
Okay.
So case 2, 27-year-old man with opioid use disorder and stimulant use disorder on Sublocade 300 monthly. He did have a trial of going down to 100 milligrams at one point and started using again when that happened, so bumped back up to 300. He's been on 300 milligrams monthly, but tells you that it really only works for about 2 or 3 weeks, and then he's kind of struggling for the last half of the month in between the injections. Wants to know what you can do. So what would you guys do for this? Are there any issues with coverage when doing more rapid inductions more than monthly? So far, no. I can answer the question with more confidence for treaty. So treaty definitely has continued to cover injections even for Q2 weeks on an ongoing basis, and we have not run into any issues. I don't have as much confidence in saying that for EIA. So if you do start doing this and you start seeing problems, I would very much like to know about it. Increased frequency, maybe biweekly doses. Yeah, exactly. So that's exactly what I would do with him. Is actually just get him to book an appointment for 2 weeks. And if he's feeling well at 2 weeks, then we'll book him again for 3 weeks. If he's feeling well at 3 weeks, we'll book him again for 4 weeks. But at that 2 or 3 week interval, if he's starting to have some withdrawal symptoms, we can give that next injection. And so the sweet spot might be 3 weeks. And again, it may actually only need 3 or 4 times of 2 weeks before you can start spreading it out a little bit, and just get them onto a regular plan. And for some people, it is actually ongoing at maybe a 3-week interval, for example. Good. Case 3. This is going to be the last one we're going to do, actually. I have a few more, but we're running out of time. So 24-year-old woman, G2P1, 28 weeks gestational age, brought in from Garden Hill to obstetrical triage because of cramping and spotting. And after she was obstetrically cleared, was sent to RAAM clinic. She's reporting use of 4 to 6 stillies a day. Last use was 2 days ago. What are some of our options for supporting her? Does Garden Hill have a pharmacy? No, they don't. It's a remote fly-in community. They have a nursing station, but they do not have a pharmacy. Yeah, so recommendation for a traditional start, then a transition to Sublocade. So I agree. This is somebody who, prior to some of the movement to starting to use Sublocade in pregnancy, would have likely been offered a Suboxone start and then actually stay in Winnipeg for a good chunk of her pregnancy, or potentially go home with some for a period of time with some more sort of liberal take-home doses of Suboxone. But there's some hesitancy around having lots of medication within communities. So this previously would have been somebody who likely would have stayed in Winnipeg, but if she wants to go back home for now, it would be very appropriate to have a conversation with her about getting her started on Suboxone and then Sublocade, and then she only has to come into the city once a month. Or sometimes we can, in some communities, we're working on options to get people their care within the community as well. There is a recommendation that Sublocade can be given by the nursing station if patient agreeable. Depends. I entirely agree. Sublocade is sort of a normal nursing function, and the College of Nurses agrees with that. So it can be given by nurses, but it is something that we've typically had a little bit of difficulty getting buy-in from nursing stations to be able to do that. Just because they have a lot of other things that they're pressed to do as well, and often short-staffed. That is where I think we're going to stop today. Thank you for your participation. We do have a couple more minutes for some last-minute questions, but we have to be out of here by 9:25, they tell me.
That's right, Erin. I see some comments coming in, people saying thanks for the presentation. And yeah, mostly people just saying thank you at the moment, but we can wait a minute and see if any other questions come in.
There is a question about, was the macrodose scenario then Sublocade the next day in the hospital or community? It was in the community. It was in the RAAM, one of the RAAM clinics that we did that.
Mm-hmm. Okay. I see another question. What is a microdosing kit?
So a microdosing kit is, when I reference that, is we have pre-made bubble packs in RAAM clinics for microdosing. So a typical course of a microdose would be a 0.5 milligram of buprenorphine twice a day on day 1, then 1 milligram twice a day on day 2, then 2 milligrams twice a day on day 3. So we have pre-done bubble packs that we can give people when we're doing a microdosing start in RAAM, so that they don't have to go to the pharmacy to get that medication.
Okay, thank you. Another question is, how many days does it take to get to the desired dose using microdosing?
So typically 5 or 6 days, because with that sort of 0.5 milligram, 1 milligram, 2 milligrams, then typically we'll do 4 milligrams BID, then 8 milligrams, and it's on that day 5 that we see people back in clinic and we escalate the dose to whatever they're going to need. So it's typically 5 days. Whereas a traditional start, we can get people sometimes to their therapeutic dose on day 1.
Okay. That looks like that was our last question. So if there's nothing else, then Erin, thank you so much for doing this. We're very grateful for your experience and for for you sharing all the things you've learned over the years with us, and of course for your work in our system here in Manitoba.
Thanks, Daniel.
So thank you so much, everybody, for coming, and we will see you at the next session.